All right, so good morning, everybody, and a very warm welcome to this webinar targeting or talking today about autoantibodies in COVID and long COVID. Because if you now look into various clinical and research communities, there's a lot of discussions ongoing whether there might be more cases of thrombosis and autoimmune diseases on the horizon. But before we start, let us quickly introduce ourselves. Who are we? Today it will actually be two of us presenting this webinar to you. So me is Yasmin San. I work as a product manager for the autoimmune diagnostics at Human. And today I will present together with Carola Henche, who is the product manager for homeostasis and diabetes reagents also at Human. We are very happy we had so many signups because this actually shows already the interest in this overall topic. Before we start, there's a quick disclaimer, of course, so just be aware the content we present today is state of the art, so the research is still ongoing. It is official statistics. We compiled it to our very best knowledge, but we cannot claim that this completes everything that's right now known on this planet, as COVID is still new, as it is still an ongoing pandemic. A lot of the results we will discuss today are preliminary. Nevertheless, we hope you will find it very interesting because a lot of this is really brand new as insights, and we are very excited about it. Organizational matters, just let us know in case you do have issues with sound broadcast. Use the chat function for that, please. To give you an idea, we will take about 45 minutes. We will have 2 surveys along the webinar, so you will have about a minute to answer those. Because of course we are also curious because we cannot do this face-to-face due to the ongoing pandemic. So it's nice to interact with you as people have been listening in. If you have questions, write them please in the chat function again. We will look into those at the very end of the webinar. So be patient. If something comes along the way, we will look into this, as said, at the very end. And for now, I think as we have all of this set, to give you a quick idea of what we will be talking about today. So we will start with an overview about the virus itself, so SARS-CoV-2, and then we will go from there towards autoantibodies and how these are linked to autoimmunity. And from there, we will actually look into a very precise example what autoimmunity or autoantibodies actually do, and this is thrombotic thrombocytopenia that can follow an infection or also vaccination. All right, just as a recap, I think every one of you is very, very much aware of this. Of course, this SARS-CoV-2 topic or the COVID pandemic has been with us for quite some time now. Especially the Americas are heavily affected by it, but depending on which area you look globally, there are various waves happening to a various extents. So it is a topic that concerns everybody everywhere globally. Now, if you're very much around SARS topics, this is something you will be very, very familiar with. But if you don't deal with this every day, then we want to make sure that we all start from the very same level, because we might come back to some of these terms later throughout the presentation. So the SARS-CoV-2 virus is part of a full family of viruses. So the coronavirus is all RNA viruses, they're all enveloped and they're all positive sense single-stranded RNA viruses. There are 2 viruses that are related to the virus that we see right now. And this is the SARS-CoV, so to say, like the first generation of it. And then there's the MERS-CoV, that's the Middle Eastern Respiratory Syndrome virus. Now, if you look at it from a genetic perspective, you will realize that there's an 80% overlap with the first generation, so SARS-CoV-1, if you will, and 50% with the Middle Eastern version roundabout. This whole genome overall builds 14 so-called open reading frames. This is like the encoding parts to build proteins. 2/3 go for non-structural proteins. So these are used if the virus enters cells in the body to replicate. And the remaining 1/3 are accessory proteins and structural proteins. Especially the structural proteins were very important during the vaccine development. Here, especially the spike, as the spike mediates the entry of the virus into cells. Very well. Now, before I will start talking about similarities of autoimmune diseases and our usual or the clinical patterns of SARS-CoV-2, I actually would like to give a quick poll with you because I wonder whether you have any idea of the clinical factors that go along with this. And if possible, I would actually ask Carola to quickly read out loud the question to you, so we can then start the voting. So you have about a minute time.
Which are the clinical symptoms of COVID, long COVID, that overlap with autoimmune disease symptoms? Is it none of them? Is it fatigue, intravascular coagulation? Is it rash or myalgia? Make your choice.
Thank you, Carola. So please, everyone, take a good guess what is a clinical symptom that is actually very similar. So I already see a trend here because we see the live numbers, which is actually really nice. Very well. So if we look into this, most of you responded to our question, saying intravascular coagulation is a clinical symptom that overlaps. Now, keep that in mind when I now start the presentation again for you.
So we're really curious that you tell us more.
Yes, absolutely, I will. So can you see the presentation again? No?
Yes.
Very well. So you should be seeing all the presentation again after the poll. Is that so?
Yes, the clinical symptoms.
Wonderful. All right, so if you now look into everything that's reported back from hospitals, again, globally, and if you, well, then the very typical ones, and I think you all know this, is respiratory failure. You will find septic shock. You will find with ICU patients, especially having COVID. You will find intravascular coagulation. So you were very right on this one doing the voting, and you will find a multi-organ dysfunction syndrome. But surprisingly enough, this is not all. There's a lot of more symptoms. Yes, quite often they're age group specific, but nevertheless that are reported more and more. So the more we become familiar with the disease, the more distinct also the clinical symptoms are differentiated. We have two more parts that need to be looked at. That's the musculoskeletal part and the dermatology. So on the musculoskeletal part, also a lot of myalgia is reported, general weakness with creative kinase elevated levels. On the dermatology part, very well known as the so-called COVID toes. Also rashes are very often reported, necrotic lesions are reported, purpura is even reported. So a lot of symptoms. Of course, if you have patients in the ICU, it's not the one standing out the most, but they actually do come along with that. Now, the longer this pandemic takes and the more patients we actually do have, what happened is that people started looking for these so-called autoantibodies. So autoantibodies are antibodies that are normally produced as an immune reaction, but they are targeted towards the own human body. Now, up to 18 different autoantibodies were found during COVID so far. They can link up to potentially 14 different autoimmune diseases. So we look here at diabetes, we look here at vasculitis, we look here at lupus. A lot of various, also well-known autoimmune diseases might play a role or might be linked to these autoantibodies. And it's very important to know that about 30% of all COVID patients have at least one autoantibody raised against a nuclear antigen. So this is not small numbers in the end. This is really starting to be numbers and statistics that steer up the community of autoimmune diseases. Is this new, you might ask? Like, is this the first virus doing something like that? No, actually not. So there's a lot of viruses already known that are linked to autoimmune diseases and might trigger autoimmune diseases. So I brought a couple of examples with me. There are two effects or two ways how a virus can start an autoimmune disease, how it can trigger it. So it's a so-called molecular mimicry. This applies, for instance, for the Epstein-Barr virus that goes towards Graves or Hashimoto, also to multiple sclerosis. It is also hepatitis C that can lead to autoimmune hepatitis as well, measles, West Nile, and also Zika. If you look at the bystander effect, also here are various viruses that then do lead to autoimmune diseases. Again, it's hepatitis C, so slightly different pathway it takes on this. It leads to vasculitis in this case and Sjögren's syndrome. Or if you look at the herpes virus 6A, it goes to thyroiditis. So you see, it's not really new that we start linking a virus in the human body to autoimmune disease. So corona virus, as it's called in the public, or SARS-CoV-2 just might be another one behaving like this. But the indication right now is it could cause more than one. So this is what is currently discussed. Now, how would it work? So generally, if you look into the development of autoimmune diseases, this is on the left side of this graph, you have various reasons why an autoimmune disease might happen. Generally, it all comes via hyperstimulation of the immune system. So the hyperstimulation can take place due to genetics, it can take place due to hormonal reasons, or it can be triggered by environmental factors such as viruses, as I just told you. Now, if you look at a COVID-19 infection, also this virus can take either the path over hyperstimulation or the molecular mimicry, because these are the common paths for viruses to take to stimulate the body to go and become an autoimmune disease patient. Now, what are the factors, if we look into this in way more detail, that actually might be reasons why this might happen? So it's a lot happening right now. As we said, it's still ongoing research, so that's probably not the complete list. What is already known so far is we do have elevated cytokine levels. These cytokine levels usually do trigger immune and inflammatory responses. And of course, this can enhance or influence the development of an autoimmune disease. There are various interleukins that are involved here. You can see it's a full list from 1 to 18, a couple of them. All of them together activate various cells, namely CD8+, Th1, Th17, NK, NKT. And all of them together lead to an overstimulation of these immune cells, and that will lead to tissue damage. If you think back of the clinical factors I just told you about, I told you you can find necrotic tissue. So there is already the first link. Then, of course, it can be genetic deposition. This is not yet completely set in stone, of course, because this has to do with a lot of screening of patients, building statistics. But it seems especially the pneumonia we see is if you have a genetic deposition, you can very easily find an inflammatory dysregulation that leads to this. Also, having autoimmunity genetically predispositioned, you see right now that the specific autoimmunity will worsen the state of the patient. As a third, pro-inflammatory mediators can be heavily produced as well. So it's again about autoreactive T cells, again leading to tissue damage. And last but not least, it's a neutrophil activation that is observed, a so-called netosis. It is very similar to a thromboinflammatory disease, especially that's similar if you look again into the autoimmunity part. That's similar to lupus. We see it in ANCA-associated vasculitis. We see it in antiphospholipid syndrome. So it opens the door to a lot of various autoimmune diseases that might be happening as a follow-up of an infection with COVID. Now, I brought 3 examples of current research along to show you what is happening in the community right now. And having been to a conference last week, I can tell you there's a lot of discussion happening right now. It's a lot of data that are gathered, that are tried to be composed to make sense of what the community sees. So SSA-Rho is a common factor as an autoantibody if you look into autoimmune diseases. And if you see on the right side, it usually is about 10 or is below 10 international units per milliliter. Now, in these patients that were actually observed or taken care of in Japan, this was exceeded massively because we see 203 and 442 units, international units per milliliter. So it not only doubled, it really went crazy. So they saw this from the lung pathophysiology, sorry for that, that they had an idea that this might be a vascular disease, and this is why they started looking into this. The study concludes actually in asking for contributions globally, because in Japan, for instance, right now, they are not allowed for legal reasons to do full blood samples of corona-positive patients. So these are still numbers that need to be verified by a lot more people in the field, in the clinics. Second aspect, myositis. I already talked about this when talking about the clinical manifestations. So myositis is actually very commonly reported for people having COVID. The T8, the CD8 T cell overactivation is the reason here. Myalgia is extensively reported. Myalgia is like a diverse muscle pain, in case you're not familiar with this. So this is for nearly half of all COVID infected patients, something they report back. Also, patient cases of myositis can be various, of course, right? There's not the one symptom you can find with everyone. This is also what makes this disease so difficult to win over. So you can have just muscle weakness in combination potentially with classic rashes. You can have back pain with a muscle disease, even to be seen in MRI. You might have rhabdomyolysis in very rare cases as well. Now, but all of this is united in finding elevated levels of anti-MI2 and anti-MDA5 and anti-SAE1, as well as a lot of different anti-nuclear antibodies. But also this study concludes in, okay, we got a good overview about our own region, but we do need more studies. So the overall call out to the scientific community, to clinicians is, please do more screening, to provide more data. We need it to understand what we might face in the future. Antiphospholipid antibodies, you might have seen it because over the last days, a lot of the press also started tackling this topic. Antiphospholipid syndrome is an autoimmune disease characterized by the formation of antiphospholipid antibodies, namely anti-cardiolipine, anti-beta-2 glycoprotein, and lupus anticoagulant. It leads to thrombophilia, and the antiphospholipid syndrome is mostly common during pregnancy, so it leads to miscarriages and massive diseases during pregnancy. Clinical research shows so far that they can, in general, also generate thrombotic stages in the body. Now, would you say, well, data for this? Yes, there's a comparison of a healthy population and COVID-19 patients. And for the ACL, you see a rise about 6-fold. And if you look at the anti-glycoprotein 2, you see again 3 to 4 to 6-fold, depending which antibody form you look for. This is one of the rare global studies right now, because of course people can't travel so easily. It's very difficult to ship around samples, of course. Still here, the effort was made to get a better understanding what's happening, because of course it affects embryos and it affects children in the end. So around 50% of the current research indicates that autoantibodies are raised in general in the acute infection. We can see that there's a relation to thrombotic events, and Carola will give you in a minute more insights about this one. And we do see a huge similarity in pathogenesis and APS. Also looking back at the conference last week, there was a plead out to young doctors saying, please remember, in 5 years, if you see people having autoimmune diseases, check, did they have COVID? Did they have long COVID? Because there's also the discussion, may long COVID already be some sort of an autoimmune diseases after the first discussion? But all of this leads to the summary. We need more data, we need more studies to really conclude to a new and healthy understanding. And with this, I'm very happy to hand over to Carola for the second part and actually more insights into the link of thrombosis and COVID-19 infections.
Thank you, Yasmin. So you can see my screen now. So further autoantibodies that are related to coagulation are the platelet factor 4 antibodies. And before we start with an explanation what they do in the organism, we would like to have a poll again on the symptom, which is the thrombotic thrombocytopenia.
So let me help you with this time around. So the question this time is, and you should actually now see the quick poll. What is characteristic for thrombocytopenia? Is it the abnormally high level of thrombocytes? Is it abnormally low level of thrombocytes? Or is it dysfunctional thrombocytes? And you do have a very strong opinion on this so far. Again, you have about a minute to vote, so take your time, think about it. Of course, we are interested what you think is the link we see here. Very well. Couple of seconds to go
and
still.
And we can see that the trend goes absolutely in the right direction. So,
absolutely right. So about 60% of you said now that the abnormally low levels of thrombocytes are linked with this.
And this is a typical symptom of this thrombocytopenia. And the thrombocytopenia that is related to the platelet factor 4 antibodies. Oh. So you see my screen?
I think it's still mine.
Okay. So then we can leave it like this because
sure.
The transmission is not starting in my case.
Right, then I will help you get through this. No
okay,
problem.
thank you. So the thrombotic thrombocytopenia is quite common in the course of a COVID-19 infection due to the prophylaxis with heparin, and it gets there to a heparin-induced thrombocytopenia. But strangely enough, it is a miracle that that there's also patients that get a thrombotic thrombocytopenia that do not get heparin, and it is suspected that it is a cumulative effect. So an interplay of antiviral antibodies, antiphospholipid antibodies, and also the platelet factor 4 autoantibodies. And also related to adenovirus vectored COVID-19 vaccination, there a vaccine-induced immune thrombotic thrombocytopenia is observed. And it went through the media, of course, we all know. The symptoms are cerebral, venous, and other unusual thrombosis, and it mimics somehow the autoimmune heparin-induced thrombocytopenia, including the detection of the platelet factor 4 autoantibodies, and in this case, about 4 to 16 days after the vaccination. The typical symptoms are thrombotic presentations, a thrombocytopenia, which is characterized by a rapid decrease of platelet counts. It's below 150 per cubic millimeter and usually lower even. And the coagulation parameters are abnormal, like D-dimer and fibrinogen. So it is also typical that D-dimer rises up very high because of the activated coagulation and thrombotic symptoms of the body. And it occurs typically 4 to 25 days after vaccination, or in case of heparin therapy, 5 to 10 days after start of heparin, or even immediately if a patient had already contact with heparin. The mechanisms for the thrombocytopenia that is caused during COVID-19 or vaccination are not really clear, so we will start to have a look at the biological role of the platelet factor 4 and the mechanism of the heparin-induced thrombocytopenia. Platelet factor 4 is a small cytokine that is released by activated platelets. It promotes coagulation, especially during inflammatory processes. And it binds with a high affinity to heparin-like molecules on endothelial surfaces and blood vessels, and there it inhibits antithrombin activity. And the heparin platelet factor 4 complex is immunogenic, and it is the antigen in the heparin-induced thrombocytopenia. And antibodies specific to this complex are built, and as this complex is also present on the platelets, the antibodies attack the platelets, and it comes to an overactivation of the platelets that leads also to an aggregation of the platelets, to a consumption, to apoptosis, and also to a very increased coagulation activation. Thank you. So for the thrombocytopenia during COVID-19, when there is no heparin, there are just hypothetical models how the mechanisms are. So it is a fact that the platelets are hyperactivated during a COVID-19 infection, and so there's a high level of platelet factor 4 in the circulation. And it is hypothesized that these platelet factor 4 binds to the endothelial cell-derived proteoglycans, which are also increasingly present on the mostly damaged endothelial cells during the infection. And here they build again a complex that stimulates the immune system and builds anti-platelet 4 antibodies. And this again leads to the overactivation of the platelets, to the aggregation, to the consumption, to the decrease of platelet count, and also to the overactivation of plasmatic coagulation. However, during a COVID-19 infection, the autoantibodies are not suspected the only reason. We also have, of course, the antiviral antibodies and maybe also antiphospholipid antibodies that all together cause the overactivation of the coagulation system. And the thrombocytopenia that is related to the vaccination for COVID-19 with adenovirus vector mediated vaccines is also still unclear. So research are going on, and it is suspected that the adenovirus vector might play a role in the activation of the platelets, as it is known that adenoviruses are activating platelets. However, the concentration is not very high. Additionally, also the spike proteins are suggested to activate the platelets, and combined we have an increased level of platelet factor 4. And the spike protein itself was originally suspected to have an influence, but it has shown that there is no cross reaction with platelet factor 4 and platelet factor 4 heparin complexes in studies. So the spike protein alone is not the reason for this overreaction after vaccination. So the hypothetical model also here is that this increased level of platelet factor 4 in some patients bind complexes with the anionic proteoglycans shed from the endothelial cells, and the immune system gets overactivated and attacks the platelets, and we have the well-known symptoms of a thrombotic thrombocytopenia. The International Society for Thrombosis and Hemostasis released a few months ago a diagnostic flow chart how to react in these rare cases when there is a vaccine-induced immune thrombotic thrombocytopenia. It is less than 1 in 100,000. However, if those patients appear, you have to react very fast. And so they recommend to have first, of course, the signs, the typical symptoms of thrombosis, leg pain or swelling or chest pain after a vaccination. If there are signs, then it is recommended to have immediately imaging measures and also to order a complete blood count. If then the platelet count is below 150 and additionally a thrombosis is present, this indicates that it is a possible VITT. And then further coagulation assays are recommended like PT, APTT, fibrinogen, and D-dimer. And also it is recommended to order an immunoassay, like for example, the HIT ELISA, but also rapid tests are available. If the platelet factor for ELISA is positive, a VITT is confirmed and an immediate treatment is necessary, for example, with immunoglobulins on steroids. And especially important it is that no heparin is allowed to be administered. Alternatives, anticoagulants should be administered, like, for example, agatroban. The platelet factor for ELISA assays are typically not available in all laboratories, and so the society recommends, if this is not available and a reference lab is not available, to have a look at the coagulation parameters. So if the D-dimer level is 4-fold increase, this also indicates that a VITT is there and can function as a confirmation for the VITT. So summing up on this exciting topic, so autoimmune antibodies are detectable during and after COVID-19 infection, and even in rare cases after vaccination. And there seems to be also incidence that they play a role in the long COVID-19 disease. It is still not unclear if past COVID-19 related autoimmune diseases for recovered patients will be increasingly present. And so several studies need to be conducted for a deeper understanding how autoantibodies related to COVID-19 will present in the future. So then we are at the end of our webinar. We thank you for your attention and we are glad to answer your questions and discuss with you your comments. And additionally, if you like, on our website, there is a dedicated site for COVID-19 related informational material that you can have a look at. And additionally, also regarding the coagulation diagnostics, you can find informational sources also on our website.